Normally, Dr. Kush Desai, who's our medical director for this program, will be facilitating, but he's actually being a doctor today and having to see patients. So I'm Doug Patton. I'm the campus dean for the Medical College of Georgia here on the Southwest campus, and I'll be facilitating today as part of the Georgia Colorectal Cancer Control Program. Make sure again, please, as you join, that you put your full name, name and location of your clinic, your role, if you don't mind, as well as your email address. There are plenty of examples in the chat. Please do that. It lets us take attendance, if you will, but also have a way to reach out to you if we have questions later. So with today's, let's go ahead and start sharing the slides. And with today's session, we'll start with the agenda as normal. This is the introduction. We'll move into a didactic shortly by Dr. Thomas Imperiale, and then follow that up with a case presentation by Marybeth Curtis and her team, which I'll introduce later as a case presentation. And then we'll have some time for discussion at the very end. I'm going to move through this quickly because we do have two robust presentations today. We all know what Project ECHO stands for. So let's move along to the next slide. We go through this every time. All sessions are recorded, and by participating and staying on, you're consenting to being recorded. And a reminder that these are not secure conversations, so please do not share any PHI during this time. Next slide, please. All right, so we do collect the data for all the purposes that we review every single time. Next slide, please. And just some general reminders to mute your microphone when you're not speaking, unmute when you do need to speak. You can also type questions in the chat, and we really encourage you to put your questions in the chat so that we can be as efficient as possible when responding to questions and getting our presenters to answer those questions. If you need to speak, raise your hand. We'll try and catch your electronic hand by using the raise hand icon in the bottom. Leave your cameras on if your bandwidth will stand it so that we can see the faces as we're doing the presentation. And using that gallery view so you can see as many faces as possible. Technical problems you can put in the chat, and Brenda and Christopher will be looking for those. Next slide, please. So this is a disclosure which is required. We just need to disclose on behalf of Dr. Imperiale that he and his group do receive some funding from Exact Sciences, and you can see the details in that. These slides, of course, will be available post-production if you need to review the detail, but that is the one disclosure that we need to make today. Next slide, please. So it's my pleasure at this point to introduce Dr. Thomas Imperiale from the from Indiana University Medical Center. He is a gastroenterologist and clinical epidemiologist. He's been on the faculty of IU School of Medicine since 1996. He sees patients in the inpatient and outpatient setting, does basic endoscopy, but as we were just discussing before we got started, he's heavily involved in teaching medical students and residents, mentoring students and residents and faculty, and conducting outcome research on a number of topics, most of which are relevant for screening and surveillance of colorectal tumors. His talk today is risk factors for post-colonoscopy colorectal cancers. The presentation will last about 20 minutes. There is a warning notification that Christopher will sound if we get to 2 minutes left. And then we'll try to reserve some time for questions. But again, I'm going to ask you, please, if you do have questions as it's going along, please put those in the chat so we can kind of consolidate those to post to Dr. Imperiale when he finishes. All right. Dr. Imperiale, I'm going to turn it over to you at this point. Thank you for joining us.
Great. Thank you, Doug. And welcome, everyone. Good afternoon. So I'm going to talk about risk factors for 5-year post-colonoscopy colorectal cancers. And if there's time, say something about up and coming screening tests, a little bit of a prelude to those. Next slide. I'd like to acknowledge my collaborators. Next slide. And the VA for their support of this project. So post-colonoscopy colorectal cancers, we call them interval cancers, are colon cancers that are diagnosed after a colonoscopy that does not find a colon cancer. And they're defined in various ways. but the 5-year post-colonoscopy colon cancer rate is the predominant definition of those. And they occur, about 5 to 6% of all colorectal cancers occur after a colonoscopy that does not show them. It's felt to be a true measure of colonoscopy quality as reflected by a metric known as the adenoma detection rate, or ADR. So this is a major reporting metric for all of us as colonoscopists. It's the percent of procedures in which we find one or more adenomas, and it's supposed to be in a purely screening setting. But in recent years, that definition has been relaxed so that it's in under any indication and all indications combined. And knowing these risk factors for PCCRCs, other than a low ADR, is important for ensuring high quality colonoscopy at the levels of patient, provider, and system. Next slide. So this is from a study published just a year ago in JAMA, showing that as the ADR goes up, the risk for post-colonoscopy colorectal cancers, which is on the y-axis, goes down, and vice versa. So you see that top curve that's kind of in a like brown color, that is associated with the lowest ADR, adenoma detection rate, of less than 20%, whereas the blue line, which is the highest rate, more than 50%, is associated with the lowest risk of a post-colonoscopy colon cancer. But after that, we really don't have a good feel for which factors increase risk. Next slide. There's been a lot of data published on this, but it's almost all from other countries. And I list on here and the next slide these studies, and they're from all countries that are outside the US, mostly from Europe. Most of them are case control studies, if you could go back one slide, and they vary in their definition of PCCRCs from 10-year to, if you want to advance one slide, 3 years. So there's a wide definition. There are varying sample sizes, different study designs, and they all show different results as far as risk factors for colorectal cancers that occur after a colonoscopy. These are the most recent 3 studies showing a certain age range, the presence of diverticulosis, a previous polyp or proximal cancer, less than deep sedation, which may be a marker for how well you could do the colonoscopy, having a non-GI endoscopist do it. And then this last study from Denmark that was published a couple of years ago just wanted to test whether type 2 diabetes was a risk factor and found that it was not. Next slide. But I should add that there's been very few studies that have been done in the US. So we used VA data to study risk factors for these post-colorectal cancers at 5 years. And we did it based on whether a polypectomy was performed at the index colonoscopy or not. We hypothesized that risk factors would differ depending on whether a polypectomy was performed during that index colonoscopy. Next slide. So here's the study design. It's a little bit complicated, and we'll move from right to left here. We started with cases who, by definition, had a colon cancer more than 6 months, but up to 5 years after an index colonoscopy. And the controls simply did not have a colon cancer, either within 5 years in the case of a polypectomy or 10 years in the case of no polypectomy on that index procedure. We then matched them, the cases and controls 2 to 1 on age, sex, and the date of the colonoscopy. And we did the analysis stratified by whether a polypectomy was done, and the exposures are over on the left. So those are all the categories of risk factors that we examined and tested this for. Next slide. So here's another way of looking at it. Our inclusion criteria were people, at least for the cases, recruited from 2003 to 2013. So this is when they were diagnosed, ages 50 to 85. And again, they had to have a cancer 6 months to 5 years within of their index colonoscopy, with or without polypectomy of a neoplastic polyp. We excluded people who'd had an adenoma or a cancer prior to this index colonoscopy, who had a colonoscopy less than 5 years before that index colonoscopy, those who had IBD or inflammatory bowel disease, and those who had had a prior colon resection for a reason that we couldn't determine for possible CRC. And you see our controls here, very similar to the cases, except they didn't have a colon cancer within 6 months to 5 years after an index colonoscopy. And that interval varied based on whether they had a polypectomy, allowing for a greater interval for the no polypectomy group, and the exclusion criteria were identical. Next slide. These were the candidate risk factors. We looked at demographics, health factors, and then we were most interested in factors that were related to that index procedure, including where it was done, how well it was done, who did it, what the findings were, and what the recommended follow-up was. Next slide. We got our data from the corporate data warehouse, which at the VA houses a lot of clinical data on patients, and it draws data in from other sources as well. We linked our data set to Medicare data in case patients have had colonoscopies done outside the VA, which we did in fact find. We looked at CPRS, which is the VA's electronic medical record, and we double-checked findings about finders using the NPI registry. Next slide. So we separated our analysis looking at polypectomy cases and controls, and analyzed those separately from no polypectomy cases and controls for descriptive features. We did bivariate analysis and then created our multivariate models. Next slide. So this is how we derived our cases. We started with nearly 600 cases without polypectomy and about 530 with polypectomy. We had various reasons for exclusions that I described earlier, ending up with 402 cases without polypectomy, 404 without. We were targeting 404 based on what our statisticians told us our sample size needed to be. Then we ended up excluding 2 of the cases. Next slide. And then here were our controls with and without polypectomy, who again had an index colonoscopy and didn't get colon cancer after that index colonoscopy. And we had 804 and 808 of those respectively without and with polypectomy. These are the reasons for the exclusions on the slide. Next slide. So if we look at the baseline features, we don't see a lot of differences in the people with and without polypectomy. You can see that going across, they're pretty comparable demographically. The only big difference is the percent of people cigarette smoking in the groups, where you see lower rates in the control groups than in the cases both with and without polypectomy. Next slide. And so this is color-coded. The variables in yellow have to do with where and who did the colonoscopy, and you'll see some differences here. The patients who were done, by GI endoscopists, the controls, at least for the polypectomy group, were higher. Most of these were done at the VA, and you'll see some differences in preparation quality. I'll come back to this in a moment, but in general, the controls had a higher percent of good or excellent preparation. And if you look at advanced adenomas, as you'd expect, the cases in the polypectomy group had more advanced adenomas than the controls. And also in the no polypectomy group, it was good that nobody had any advanced adenomas because they weren't supposed to have any polyps. So it's nice to have that internal check. And then last, the recommendation for repeat colonoscopy within 5 years varied based on the information with which the endoscopists had to make a decision once they had the path report. And you'll see that in the no polypectomy group, there were recommendations made for colonoscopy within 5 years in both cases and controls, but more so in cases. And we're not exactly sure why they made this recommendation, except that it may have had something to do with prep quality or with the colonoscopist's inability to see the mucosa comfortably enough to not make that recommendation within 5 years. Next slide. So here are the factors that are associated with the no polypectomy cases and control. It was Charlson score, a high BMI, which is kind of a marker for greater difficulty with a good quality prep and a harder exam as far as the endoscopist goes. Having a recommendation for follow-up colonoscopy within 5 years, or missing a recommendation for follow-up colonoscopy. And the model had good calibration and had reasonable discrimination with a C statistic, or an area under the ROC curve, of 0.7. Now, because these last two variables are somewhat subjective, and we saw that other variables were close, we took these two variables out of the model. And next slide. When we did, then prep quality came into the model, with a good or excellent prep quality being protective against having a post-colonoscopy colon cancer in this group that had no polypectomy. And if you look down below, if you look at the distribution of prep quality, you can see that those with an excellent or good quality prep, only 7% of them had a recommendation to return within 5 years, whereas not having a good or excellent quality prep, or not specifying, was associated with a higher return recommendation within 5 years. Next slide. Here are the independent factors that were associated with polypectomy. So this gets interesting. Having your colonoscopy outside the VA had an odds ratio of almost 3. Having a non-gastroenterologist do it increased your odds by 67%. Having one or more advanced adenoma, as you might expect, 2 or more proximal polyps, so beyond the splenic flexure, either in the transverse colon or more proximal to it, and then getting a surveillance recommendation within a year. And usually that's going to be for a piecemeal polypectomy, where the endoscopist wants to check their handiwork and make sure they got the lesion out. So that recommendation to come back in short term was the most powerful risk factor. Again, we had a model that fit well, but it wasn't all that discriminating at 0.71. Next slide. Our study had limitations. We're using sort of an old cohort. It predates the widespread use of high definition scopes, narrow band imaging, which limits the spectrum of light and helps us delineate patterns in the mucosa that will tip us off as to whether polyps are there. It was before we started getting our own adenoma detection rates reported to us, and that's been a stimulus to bring those up, and other technologies that have become available, like CAPS and other things that help us see the mucosa. The other limitation is that there's potential for residual confounding, because there were factors that weren't included here related to patient risk, like diet and exercise. Colonoscopy factors, we don't know the ADRs of the colonoscopists, because they weren't being recorded routinely from 2003 to 2013, but they have been recently, and that's a reason we're thinking about redoing this study. And also looking at facility factors, specifically, what does that VA have in place to do surveillance after patients have their colonoscopy? We used a specific definition of PCCRC, 5 years. Others use 3, others use 10, others use whatever guidelines recommend beyond that interval, or if they occur within that interval. So PCCRCs are variably defined. And of course, the last the limitation is that, as far as generalizability, since we studied the VA, we were 97, 98% men. Next slide. But we can conclude that several factors are associated with these post-colonoscopy colon cancers within 5 years, and some of them are modifiable. The most important is the recommended colonoscopy follow-up interval, either for rescreening or surveillance. So making a recommendation reduces risk. Not making one increases risk. These factors may be useful for tailoring the interval and using them as targets with which to improve quality. So that's the talk on post-colonoscopy colon cancers. I think I have a few minutes. Tell me if I don't, and I can stop here if I don't.
You have 5 more minutes.
You're doing good.
Okay. So let's advance the slide, and I'll tell you what's coming. And you may already know about this, but these data are from our big GI meetings in May, where it's really hard to find anybody to do a colonoscopy because they're all at the meeting. But if you want to advance the slide, if you are able to. So at that meeting, Guardant presented some top-line results for their blood tests for colon cancer. They They did a population-based study in average risk people aged 45 to 84 years old, recruited them throughout the US and aimed for a diverse cohort. And they have a blood-based assay that tests for cell-free DNA. All those people had their blood drawn before they underwent their screening colonoscopy, and they looked at the test characteristics for this test. In almost 8,000 people, they had 65 people with colon cancer. Another 14.2% had advanced precancerous lesions. And if you want to go to the next slide, the sensitivity for colon cancer of this blood test was 83%. It was lower for stage 1 and 2, 72%. It was lowest for stage 1, 55%, but it picked up all the other cancers in the other groups with a specificity of 90% for those who had no neoplasia at all on their colonoscopy. The specificity was lower if you counted non-advanced adenomas. The sensitivity for advanced precancerous lesions was 13%. I would submit that all of that serendipity because the prevalence of these in the population was greater than that. So anything they picked up was serendipity. It was probably a false positive. And the biology would support that it's really hard for a blood test to detect a precancerous polyp. But it does meet the criteria for reimbursement by CMS. Next slide. And then there's the study by genioscopy if you want to advance. This was a prospective cohort study of a multi-target stool RNA test and FIT, where they looked at sensitivity for cancer. And again, everyone was having screening colonoscopy and completed the test. The sensitivity for colon cancer was 94%. With 45% sensitivity for advanced adenomas and specificity of 88% for clean colons. And the stage-specific results are not yet available. And finally, last is the second version of Exact Sciences study, which wrapped up in the spring with top-line results reported in June. If you're able to advance the slide. And this was also done in a screening population. If you want to advance the slide. And advance. And advance. And this now includes 3 methylated DNA markers and a control gene, which is the reference gene, and hemoglobin. Next slide. And this is the last one. So here's the reason they did the study was to try to improve the specificity. You see the middle column is the current version of the test, and the column on the right, highlighted in yellow, is the new version. So the specificity did improve from just under 87% up to 91%, and with no findings went from 90 to 93%, with a small uptick in sensitivity for cancer as well as high-grade dysplasia, and essentially the same results for advanced precancerous lesions. So I think eventually we're going to see this new test replace the current version of Cologuard sometime in early 2024. And that's my last slide. Thanks for your attention. Happy to take questions now or defer till the end.
Sorry, I was having a hard time finding my cursor. Thank you very much. That covers a lot of really, really interesting information. We do have a couple of minutes if someone has a question now. I don't see anything in the chat. Dr. Hotz, I see your hand up.
And thank you for an excellent presentation. And one of the great challenges we have in the primary care world, and the first one is knowing the adenoma detection rate of somebody we're referring to. It's quite often difficult to find that. And any recommendations have how to find that? And the second one is, it is maddening, and I know on the National Colorectal Roundtable, the Community Health Center Committee, this has been a common issue. We quite often get the report that a colonoscopy has been done, but the final recommendations pending pathology, and we never get that, and the patient never gets that. How common are these issues, and what is the big GI Society doing about it, and what can we do about it from the field?
Yeah, that's a great question, Jimmy. And it's not really an issue where we are. So I sort of shake my head when I hear that there's no final recommendation made, because the organizations here, we all have these template letters that go out based on colonoscopic findings that we have to sign off on, if not dictate them ourselves. So that's not an issue here. And it's not really in any of the practices that I know of here. But I think the process improvement process, quality improvement process, has to take place from within the individual medical centers. I think I don't know that the AGA or ACG or ASGE are working on anything except to make the recommendations to say how important it is to know the adenoma detection rates. I think we need some study done, because I think the ADR itself is going to end up getting overhauled, and we're going to have a different metric, and probably a better metric that'll be a combination of adenoma detection rate, sessile serrated lesion detection rate, now that the pathologist can agree on what they see, and maybe the adenomas per colonoscopy. But you have probably heard and may know that it's possible to game the ADR, the so-called one and done phenomenon, where you find an adenoma and then you sort of ease off a little bit because you've found your adenoma, you're going to be bringing that patient back. This is why the ADR, although it's a good metric, may not be the best metric. But to answer your question, I think those processes have to take place from within the organization. And the other thing is that most places are recording ADR, and you can ask for them. I don't think that, if people want to know my ADR, I don't think that I could keep people from knowing that. They'd probably have to go to my chief and ask me. I have two ADRs, one at the VA and one outside the VA. I have to say there's a big difference in the ADR. So I don't think that's me. I think it's the patients, the indications, prep quality plays a big role. But you can get that information if you want it.
Thank you.
Great response. I think we have time for one more question. Dr. Slom.
Oh, thank you, Doctor, for your wonderful presentations. I'm also a patient-centered outcome researcher, so I find that very, informative and data-oriented. One of the quick things that I thought it might be helpful for the other audience, especially when you have, all the data that are study done in other countries with very variable outcome results on the post-colonoscopy cancer rates. How do you reconcile that? If you could just briefly tell audience, that would be very helpful. I appreciate your help. Thank you.
You mean why the results are so different?
Yeah,
the
rates are very variable, and as a outcome researchers, you take that information and somehow processes and use it for your own purposes. How do you do that?
So the risk factors are different, and I think that's because the study designs are different and the populations may be a little different, but the rates of post-colonoscopy colon cancers, when you measure them cross-sectionally, are strikingly similar. They are in the 3 to 9% range almost always, and they really hover around 5 or 6%. One of the reasons we did the study is because we felt like we needed to know, how's our VA doing? Are we comparable to these European countries? Are we comparable to Kaiser Permanente in post-colonoscopy colon cancers? And we are. Our data are not as rich as Kaiser's in that we don't have the adenoma detection rates to do those nice curves that I showed in the beginning. But it's not so much that the post-colonoscopy colon cancer rates differ. It's that the risk factors differ. And I think it's just what people are measuring, how they're measuring it. And, it also could be a function of how good the colonoscopists are in that country. But, I don't want to create any international incidents by measuring something. There's certainly enough going in the world that can happen on its own. So why add to it?
Thank you.
Welcome.
Very interesting. Again, looking at the chat, I don't see anything extra here. And I will say that if we go ahead and move on to our second presentation, we probably will have time to entertain questions not only about it, but to revisit anything that's a link between the two presentations. And I think clearly most of us caught on to the notion that at least one of the risk factors for whether or not a colonoscopy was any good or not was the adequacy of the prep, which will, I think, ties nicely to the role, at least one of the roles that the RN patient navigator serve. So with that, it's my privilege to introduce our team from the Arkansas Colorectal Cancer Screening Program. And we have a team presentation today with Marybeth Curtis, who is a nurse, program manager for the Arkansas CRCCP grant project with the Department of Family and Preventive Medicine at University of Arkansas. She also has credentials that we don't see very often. She's a wound, ostomy, and continence nurse certified in that area, and we really appreciate that. Joining her is Stacy George, who's an advanced practice RN, practice transformation outreach specialist at the AFMC, also working with Arkansas Colorectal Cancer Prevention Project, and Rosario Silva, a public health professional, who's bilingual program evaluator for the Office of Community Health and Research at University of Arkansas. So with that, I'm going to turn it over to you, Ms. Curtis. Thank you.
Great. Thank you, Doug. We are so happy to be here today. Good afternoon to everyone, and thank you for the opportunity to present today. I want to say a special thank you to our Georgia CRCCP team for all that you're doing to allow awardees to share with our colleagues the successes and the barriers of CRC screening. Today, we hope to share with you a real success story that is related to the impact of the nurse patient navigator in CRC screening in rural family practice. Next slide, please. In July, I'm sorry, could you go back one? Thank you. In July of 2020, our university, UAMS, was awarded its first CDC CRCCP program grant for 2020-2025. The Partnerships and Colorectal Cancer Screening Team, or we refer to ourselves as PICSAR for short, represent the work that's being done in Arkansas on behalf of the CDC grant. And we will be discussing our very first clinical partner in this collaboration, which is First Choice Healthcare in Northeast Arkansas. Next slide, please. The objectives that we would like to be sure and address today are to identify the nurse navigator role, to examine the barriers of implementing such a role, mainly to recognize the benefits of doing so, and we hope that your state will consider nurse navigators for your practice. Next slide, please. As PICSAR began working with First Choice on an implementation plan, it became very clear to us that there was no process in place for pre-visit planning with the patient for CRC screening. And those that had the responsibility of identifying a patient due for a screening, the nurse, had multiple responsibilities, which many times resulted in missed opportunities. Next slide, please. The first evidence-based intervention that we agreed upon as a team was to propose to administration that they support a a brand new nurse patient navigator position. The justification for implementation of the CBI being that having a dedicated nurse navigator would hopefully prevent any missed opportunities for CRC screening. A quick note, you may hear us refer to this position as an RN patient navigator and nurse navigator. We may simply be referred to them as navigator. Next slide, please. As this was a new concept for our clinic partner, the PICSAR team and First Choice nurse manager, Sandy Green, went about clarifying for administration exactly what a nurse patient navigator position would involve and who would be the best fit for such a role. Next slide, please. Some of the responsibilities that we identified were that they would help patient scheduling, manage appointments, coordinate communication, manage healthcare records, guide patients on financial aspects, find interpreters if they were needed, and to manage follow-up visits. Next slide. We also identified some qualities that we felt were important: organizational skills, attention to detail, compassion, the ability to complete a project, excellent communication skills, and we found it very important to have a thorough understanding of healthcare institutions and their processes. Next slide. Some of the day-to-day activities that were identified are scheduling appointments, coordinating healthcare activities with the patients, seeking educational materials for patients, helping patients to identify any needs that they may have in completing their screening, linking patients to proper resources, but most of all, to empower the patient to understand the importance of them understanding all of their options and their role in the decision making related to screening. Next slide. After the Pixar team and First Choice partners developed this outline, it was presented to the healthcare system CEO, Bridget McDonald, and much to their credit and foresight, First Choice administration agreed to begin utilizing one of their nurses in a part-time position as a nurse patient navigator. Since this was entirely a new position for First Choice, Pixar assisted in developing a job description, and we utilized many of the CDC guidelines in developing this role. One of the first tasks for the patient navigator was to conduct a manual chart review with the assistance of our colleague Stacy George to determine if the system's electronic health record was capturing CRC data correctly. As soon as we identified other clinic barriers, we developed 4 additional EBIs that we implemented at First Choice. With this all accomplished, we were ready to begin.
Next slide. So this is our baseline data, which shows our screening rates back in November of 2020. As Marybeth already mentioned, we just started with this grant in July of 2020, so it took a few months to get our partner on board and to start collecting their data. Now, this shows that our clinics were clearly below that 60% target that we look for them to be at to participate, and they range anywhere from 30% all the way up to 46%. I do want to point out that these clinics all vary in sizes. They have different denominators because we are a very rural state. Next slide. So year one, we were thrilled with the participation from our healthcare system and specifically our RN patient navigators. As Marybeth mentioned, First Choice got on board very quickly with the patient navigator role, and they actually moved from a part-time patient navigator to 3 full-time patient navigators. So we have 6 clinics, so each of our patient navigators are responsible for 2 clinics each in the healthcare system. We were able to see some drastic improvements that first year after the full 12 months of implementation. As you can see, our healthcare system overall went from 37.28% all the way up to almost 47% in just that first year. And the same year, we had 1 clinic that improved from 30.85% up to 42.33%. Now, I won't read to you all the numbers because I know you can look at those for yourself, but you can imagine how pleased we were with our first year of success in this program. Next slide. Again, year 2, just a quick look at the numbers, and it speaks volumes. As you can see, our screening rates continue to improve from December of 2021 to December of 2022. Now, they weren't as large of improvements, but any increases we considered a positive. We have seen quite a bit of impact, especially during this 12-month period, with different flare-ups of COVID in our areas, which I'm sure many of you have had as well. And our navigators were hit hard and had to fill in for other staffing positions. So there was a little bit of a lag in the colorectal cancer screening rates. But even with those barriers, the Pocahontas Clinic went from 47.62% up to over 50% at 51.52%, and the system overall at 49%. Now, I want to explain some of the pictures you're going to see on this slide and some of the future slides, because we've done several things to raise awareness with not only our staff, but with also our patients. And we've had some gimmicky things and they've had a lot of fun with them. And so some of these are going to be pictures that they have shared. We just really cannot praise this team enough for all they have done to accomplish this and to increase their colorectal cancer screening rates. Next slide. So here you can see our year 3 numbers. We still have a few months left in this 3rd full calendar year. But with only a couple years left in the grant, this team understood that the funding would soon be over. Because they've seen the value of the RN nurse navigator on the role of their colorectal cancer screening rates, they decided they needed to start looking at sustainability. So in March of this year, they started discussing and have now moved into working with chronic care management with their 3 RN navigators and 2 additional staff members. This chronic care management is a billable service, which helps bring revenue into their clinics, helps sustain those RN navigator roles, and also allows this team to work on other wellness things such as breast cancer screening, cervical cancer screening, and other things in the wellness realm for their patients. While this implementation has taken some time and attention to develop the team and to start moving into this new role, we have noticed their patient touches actually decline. And therefore, some of our colorectal cancer rates have become a little bit more flat. We're actually right now in the process of doing a PDSA cycle to determine the impact of the implementation of this CCM model, to identify if this team can continue to show improvement on their patient touches, continue to bring in revenue for sustainability efforts, and to make sure that they have the appropriate staffing model in place to take care of this kind of work. I will say in just a few months of doing the work, we can already see that the patient navigators touches have increased from the beginning of the CCM model implementation. We just believe as time goes on, this will continue to improve. In a few months, we are planning to do another PDSA to compare earlier numbers of the implementation compared to later this year. And hopefully on a call in the future, we'll be able to share those successes with you as well. Next slide.
This slide shows a list of recommended EBIs from CDC to increase CRC screening. It compares year 2 and 3 implementation in first choice healthcare clinics. As you can see, by year 3, almost all clinics reported full implementation of the EBIs. Only 2 clinics did not indicate that they were using letters. So I really want to highlight that EBI implementation is a result of the work done by the RN patient navigators at these clinics. Next slide, please. So this is a continuation of the EBIs. 2 of the clinics expanded their hours of operations. The only EBI where no progress was made was in providing resources to reduce transportation barriers. So the population that First Choice serves has limited resources and low incomes in this rural area of Arkansas. Many patients do not have a car to even travel to the First Choice clinics. Many of the facilities that perform colonoscopies oftentimes are an hour away. So this barrier can really delay care. Gas cars, Uber, and van services have all been declined as possible solutions to funding due to funding constraints. PICS-AR and First Choice are still collaborating and brainstorming on ways to address the transportation barrier. Next slide, please. 45 is a new FIT-T, was a PDSA cycle developed to increase CRC screening for patients near their 45th birthdays. The method, how was this PDSA cycle developed? The RN patient navigators identified patients who had upcoming 45th birthdays in 2022 using the electronic health records. And during office visits in May of 2022, providers handed out 73 FIT stool kits and provided education on the importance of getting screened. The RN patient navigators mailed out 84 FIT stool kits with birthday cards with the message 45 is the new FIT-T, and they were all signed by providers. The results, the PDSA revealed many significant findings. The return rate on RN patient navigator mail FIT kits was 21% in comparison with the return rate for provider handouts of 42%. It confirmed evidence-based research studies that provider engagement is more effective in improving patient completion of CRC tests. 12% of all return kits, they all resulted in a positive test compared to the national average of 7%. These patients with positive were scheduled for a follow-up colonoscopy. Next slide, please. Lessons learned. One of the lessons learned was that providers were hesitant to screen for colorectal cancer because many insurance companies were declining coverage for the 45-49 age group. The PICS-AR team contacted the Arkansas Insurance Division to learn why some of these large insurance companies were not covering CRC screenings for patients of this age group. And they found that some legacy plans under some insurance companies had clauses that allowed them to decline coverage. The PICS-AR team also asked CDC for guidance on how to resolve this issue. There's currently nothing that can be done, but continue to gather data. The CRC screening reduces healthcare costs. We also found that not only patients were underinsured, but that 60% of the patients age 45 had no insurance coverage. The care coordinators at these clinics have taken steps to assist patients with getting health insurance. And then another issue that was encountered was a delay in the United States Postal transportation of the specimen to the lab in rural areas due to post offices having different postage pricing. Pricing varied from $2.50 to $5, and then packaging. Some required biohazard packaging, while others had no special handling and delivery times. And to ensure timely processing of the sample and that they were returned on time, the patient navigators were instructing patients to mail their fit samples on Sundays. Next slide, please. When looking back over the last 3 years, the PICS-AR has been working with First Choice. The success, they have been significant. Improved CRC screening numbers, 3 full-time RN patient navigator positions, and significant provider buy-in, more trust for the RN, for the role of the RN patient navigator in a recognition of all that they bring to overall improve patient outcomes. Next slide, please. We just want to thank the Georgia team for allowing us to present our successes. Our emails are included in this last slide if you have any additional questions or would like to learn more about our program. I don't know if we have time for any questions right now.
We do, Rosario. Thank you to you and Stacy, and also to Marybeth for a great presentation. We have our own experiences, obviously, with patient navigation here in Georgia, and so I think we would be open to questions, or if anyone has a comment about their own experiences and how these might align. Let's see, we got one in the chat. How did you fund the patient navigator positions initially? Was that a flat amount of funding, or was it, since it wasn't covered by fee for service? So where did the funding come from to get the program started?
Well, that is a great question. And it was included when we contracted with First Choice Healthcare. Part of the funding that they received was to provide for salary for this position. So initially in year one, we we assisted in 0.5% or a part-time person, but over the period of time, they have increased to 3 full-time positions, and we assist at a percentage of those salaries. They, as we said, the great thing that we're so proud of them for is that they know that this can't go on forever. They're already working on sustainability, and this chronic care model has been great. We're going to hope that it works well for them.
The chronic care management program obviously is something that many of our providers are engaged in already. It's integrating that and not overtaxing the people who are doing that work, I think, may be one of the challenges. Dr. Hotz, I see you have your hand up. You're muted.
Once again, very good presentation. And I think it highlights the view from the field and how challenging it is. And the academic center and the work they're trying to do is to clean up that connection. One of the questions that always come up is after a positive stool test, we already know that there's an interim colon cancer rate of between 3 to 9%. But when we get a positive stool test, whether it be the fecal DNA test or the FIT test, a lot of times there's apprehension if we have a colonoscopy that's negative. And is there any data about the interval colon cancer detection rate being higher in people with positive stool test? I'll ask Dr. Imperiale, but it does come down to the field, and people always ask, well, why was it positive? Why did I have DNA in there if it wasn't a cancer? So could you answer that for us?
Jim, you want me to answer it? I'm sorry.
Yes.
Okay. So, yeah, it's a good question. I hate having a positive test and not finding anything. It is very upsetting, and it really doesn't matter whether it's a positive FIT test, and I don't find what I consider to be something that explains it. And even, and really no different for the multi-target stool DNA test. They both bother me. There are good data for the multi-target stool DNA test that if it's positive and the colonoscopy is negative and it's a high quality colonoscopy, meaning that the prep was good or excellent, that the exam was complete to the cecum, and that the withdrawal time was of a certain duration, it used to be 6 minutes, now it's 8 or 9 minutes. The recommendations are to sort of accept it as it is. Now, there's a lot that is going on there. You got to have a good prep. So that means you had to clean that prep up. You had to see things reasonably well. I think if there's any concern about it at all, by examining the report, that as primary care docs, you may have to go back to them and say, how good you didn't get to the cecum, or the prep quality wasn't very good. What are your plans to repeat it? So that's for that test. Then there's always the issue of, could there be a cancer somewhere else? And there are a couple of studies published on that suggest that what you ought to be doing, and what I do when I have a negative one, and I'm convinced that I did a decent exam, I start to ask those patients about their cancer screening and about their risk factors for other cancers. So I'll ask about upper GI symptoms. I'll want to know if they're current smokers, if they meet the criteria for lung cancer screening. Then I might go and order a CT, a low dose CT of the chest. So, because I feel like I need to figure out why this was positive. Was it a true false positive, if you will, or am I missing something? For the positive hemocults, your question's a good one. I don't know these data as well, but I do know that a negative not finding anything with a positive FIT test, the interval rate of colon cancer is higher than in patients with a negative FIT or who have a colonoscopy soon after a negative FIT. I'm sorry, I can't do any better with that, but that's something to keep an eye on. Especially,
that's something our Navigator team,
yeah,
we especially want to get those people in at 1 year, not the 2 years, sometimes the slip that we have.
Well,
so it really tells us to pursue these people.
Well, absolutely. I mean, the positive predictive value of a FIT test is 30 to 35% for an advanced adenoma. There is no indication that's higher than that for advanced adenomas, and that includes cancers. So those patients have to get in, and our literature says after around 120 days, what you tend to see is worse. So and I think 120 days is a boatload of time. We want to get those patients in within 30 to 60 days. But the literature suggests that 90 to 120 days, after that, you start to see worse things than when you scope those people before the 90 to 120 day interval.
Thank you.
Thanks for that. I do, maybe we could get some comment from some of the crowd or from our Arkansas presenters on that notion of how are we actually measuring that interval between a positive stool-based test and doing that? There's clearly a role for patient navigation in contacting those patients, following them up and making sure that they do it and that they get a good prep, that they get the instruction to do the good prep. Any comments on that before we wrap up?
Stacy, would you like to address that?
Stacy, I think she called you out.
Oh, that's okay. I don't mind answering it. I'm just trying to share the love here. That's part of the problem that we've been having is we have such limited resources. You know, states are really fortunate to have, we have a lack of providers that do colonoscopies, and we have a lack of facilities that offer them. So we're looking at, you know, long time waits for these follow-ups. But in the PDSA that we did, where we did have the positive fit results, each one of those patients did receive a follow-up colonoscopy. It may have been 3 to 4 months afterward, but they did receive follow-up.
That's good.
So, yeah, one of the recommendations we've been making to our clinical partners is to try a stool-based test, or really recommend a stool-based test for patients that are at average risk, and not be using colonoscopies, you know, which of course is the provider preference, for just average risk, because we have such a backlog of availability.
Absolutely. Okay, that's great. With that, I'm going to turn it over and let Dr. Islam wrap us up and carry us out. I would just want to say thank you again to our presenters, and also to our out-of-state participants from South Carolina, Nebraska, South Dakota, Virginia, Missouri, North Dakota, and Alaska. Thank you, Dr. Islam.
Well, thank you, Dr. Patton, for leading us through this presentation today. And I also thank you to the presenters for their wonderful presentation. I wanted to extend that all participants are eligible for CE credits for today's session. To claim CE credits, please follow the link or code posted in the chat session. In terms of the moving forward, we will need volunteers for presentation, case presentation in our future sessions. If anyone would like to have present a particular case, please communicate with us at au_CRC screening@augusta.edu. Next session, we just wanted to let you know that we have session every month, but the next month session, which is in September, that's going to be the second Wednesday of the September due to a holiday, Labor Day weekend. Otherwise, we have sessions every first Wednesday of the month. The global session for everyone open, which is on Wednesday, October 4th. Next month's session is restricted to our grantee participants only. If you have any questions, comment, please let us know through email at au_CRC screening@augusta.edu. Again, thank you everyone for your attending today's session. We will see you in our next session. Thank you, everyone.
Thank you.
Good night.
Thanks, everyone.